All right, everybody, we're jumping into chapter 57. This is a very useful chapter, I think, and one that I wanted to try to cover earlier in the semester, but it just didn't fit in the flow of what we were trying to do. But essentially in these ones, we're talking about the cyclooxygenase inhibitors, so our COX inhibitors. We're talking about our NSAIDs and acetaminophen. And these are two drug classes that we use all the time. People can get them over the counter, obviously. You are going to encounter them a ton as a prescriber, that people are on them or you were telling them to take them. So let's talk a bit about how they work and why they work and what we need to know about them. The family of the cyclooxygenase inhibitors consists then of aspirin and other drugs. They're useful because they can suppress inflammation, they can relieve pain, and they can reduce fever. So if you ask yourself, what are the three reasons that we give NSAIDs or acetaminophen? It's to suppress inflammation, relieve pain, and reduce fevers. Aspirin and only aspirin can also protect against myocardial infarction and stroke. So even though aspirin falls into the same category as like ibuprofen and acetaminophen, it's only aspirin that's used in that realm in the cardiovascular world for prevention and treatment, right? But the reason we group them all together is because all of these effects between these drugs are produced through one central mechanism, which is the inhibition of the cyclooxygenase. That is the enzyme responsible for the synthesis of prostanoids, which are your prostaglandins and those other related compounds. So if I give a COX inhibitor, I'm inhibiting the synthesis of prostaglandins, essentially. The same mechanism underlies their principal adverse effects then, which is gastric ulcers, bleeding, and renal impairment. Okay. Cyclooxygenase inhibition also underlies MI and stroke, which can occur with most of these drugs, but not with aspirin. Okay, so how do the COX inhibitors work? Okay. Cyclooxygenase is always called COX, C-O-X. And COX is an enzyme, converts arachidonic acid into prostanoids, which are prostaglandins and like prostacyclin, thromboxane, etc. So to understand how this class of drugs work, we have to understand COX itself. So cyclooxygenase, we need to know what that's doing so that I know when I inhibit it by giving that drug, what am I doing? Okay. So how does cyclooxygenase work? A couple things. It's found in all of the tissues and it's present in multiple processes of the body. Specifically at sites of injury, COX catalyzes the synthesis of your prostaglandin E2, which is called PGE2, and prostaglandin 1,2, or I2, which is the prostacyclin. So when you have an injury, COX is the enzyme that's responsible for the synthesis of your prostaglandin and prostacyclin, and that is what promotes inflammation and sensitizes the receptors to painful stimuli. So it's the presence of that COX in the tissue that's causing inflammation and pain. In the stomach, COX is also present, and COX promotes the synthesis of, again, prostaglandin and prostacyclin, and that helps protect the gastric mucosa. So its presence in the stomach is good. Three mechanisms are involved, okay, in the stomach. It reduces secretion of gastric acid, increases secretion of bicarbonate and cytoprotective mucus, so the good mucus, the good secretion, and it's involved in the maintenance of submucosal blood flow. So having COX as an enzyme present within the stomach is a good thing because it protects that gastric mucosa. In platelets themselves, COX as an enzyme works with the platelets to promote the synthesis of the TXA2, the thromboxane A2, which stimulates platelet aggregation. So that's a good thing when your platelets come together and make a clump, right, to help protect the bleeding, like at the site of an injury. In blood vessels, COX is present, and as that enzyme works, it synthesizes prostacyclin, and it's that process then that causes vasodilation. In your kidneys, the COX catalyzes the synthesis of your prostaglandin and prostacyclin, which promotes vasodilation, which in turn helps maintain renal blood flow. So having COX as an enzyme active within the kidneys, helps maintain our kidneys' blood flow. In the brain, COX as an enzyme mediates fever and contributes to perception of pain. It's also present in the uterus that will help be involved in contractions. So it's important to appreciate that prostaglandins, prostacyclin, and the thromboxane act locally, and these compounds do not affect sites distance from where they were made. So the COX that's produced in the stomach, the COX that's produced in the brain or the uterus work only in those areas. Okay. Cyclooxygenase, the COX, has two forms. We call it COX-1 or COX-2. Okay. Let's talk about those. COX-1 is found in practically all tissues, and it mediates the quote-unquote housekeeping chores. Okay. So important amongst that is it's protecting the gastric mucosa, it's protecting our renal function, and it's promoting platelet aggregation. So COX-1 is a good one. It's helping keep all of those things functioning, keeping the house clean and organized and working well. Okay. But in contrast, COX-2 is produced at the sites of tissue injury, and that's where it mediates inflammation and pain. Okay. COX-2 is also present in the brain, the kidneys, and the blood vessels, and the colon, where it can contribute to colon cancer. So that's why down the line you'll hear about COX inhibition with colon cancer. So because COX-1 primarily mediates beneficial processes, and whereas COX-2 primarily mediates those quote-unquote harmful processes, COX-1 has been dubbed the good COX, and COX-2 has been known as the bad. Table 57.1 in your book has a nice little table there to help show you like where the location is and what COX is there and what it's working on and its response to that and effects then of COX inhibition, right? So for example, it's saying if on table 57.1 in your book, it's saying stomach is where COX-1 is. It's working on prostaglandin and prostacyclin. It's good because it provides gastric protection by increasing bicarbonate secretion, increasing mucus production, decreasing acid, and maintaining submucosal blood flow. So if I give a COX inhibitor, I can cause gastric ulceration because I'm mucking now with its protectiveness from that. Okay. If you go down a little further and you're talking like blood vessels, that's where we're talking about COX-2, which is quote unquote bad. It's working on prostacyclin and it causes vasodilation. So if I give a COX inhibitor, the bad effect could possibly be, could promote an MI. Okay. So COX-1 and COX-2 both work at the kidney. So I want to point that out. In the kidney, you have both of those present. They work on the prostaglandin, the prostacyclin, and they're good from the COX-1 part because it maintains your renal blood flow. But if I inhibit that COX-1, I can cause that renal impairment. That is why NSAIDs could be bad on your kidneys. Okay. So this is a nice little table that you can refer to. That's a good one. The important part to take away is that having cyclooxygenase around can be good. So COX-1 is good. So when I give a COX inhibitor and it can't distinguish between 1 and 2, the bad parts about giving the COX inhibitors is that I can cause gastric erosion, bleeding tendencies, and renal impairment. So that makes sense, right? Because we can understand now there is part of the cyclooxygenase that is good to have in our body, and when we give COX inhibitors, we can have bad side effects from that, okay? But inhibition of COX-1 is where we get protection against MI and stroke related to reduced platelet aggregation with aspirin only. When we inhibit the bad COX, it can also give us these largely beneficial benefits by decreasing pain, inflammation, reducing our fever, and protection against colorectal cancer. But when we also impair COX-2, we know we're going to cause possible renal impairment and actually possibly increasing people's risk for stroke and MI. So like ibuprofen, as an example, is not aspirin. Aspirin's protective against MI and stroke, secondary to platelet aggregation. Ibuprofen, on the other hand, can promote MI and stroke, secondary to suppressing vasodilation. So that's where people get pretty confused. But remember, even though that aspirin falls into this category, they're very different. Okay, so now let's talk about the drugs, the COX inhibitors. They fall into two major categories. There's one set that has anti-inflammatory properties. Oh, sorry, meant to put these up there on for you. There's one set that causes the anti-inflammatory properties, and then there's a set that don't have anti-inflammatory properties. So essentially, your NSAIDs are non-steroidal anti-inflammatory drugs. So aspirin, Celebrex, ibuprofen, naproxen, and then the other one's acetaminophen. But that's how those are considered to be grouped. So an NSAID does not include acetaminophen. Important point. People, I see that quite a bit said incorrectly in practice. The first generations of NSAIDs, I'm sorry, back up a second. There's two generations of NSAIDs. There's first generation NSAIDs and then the second generation of NSAIDs. So the first generations are ones that are aspirin, ibuprofen, naproxen. The second generation are the selective COX-2 inhibitors, which are the COXIBs. So meloxicam and celecoxib fall into the second generation selective, okay? But let's talk about these first generation ones, so our true NSAIDs of aspirin, ibuprofen, naproxen. Because they inhibit both forms COX-1 and COX-2, they are unable to suppress pain and inflammation without posing a risk for those serious side effects, right? The gastric ulcer, bleeding, and renal troubles, okay? So first generations affect COX-1 and COX-2, and because of that, they have a way higher tendency to have the problems of gastric ulcer, bleeding problems, and renal impairment. In contrast, because of their selectivity for COX-2, which is bad, the second generation NSAIDs, in theory, can suppress pain and inflammation while possibly causing fewer effects than the first generation. However, in reality, what we've seen play out is that the COX-2 inhibitors appear even less safe than the first generation agents, owing to an increased risk for MI and stroke. Okay, so let's break that down a second of what I've said. This is really important because you guys are going to be educating people about this, and I want you to be able to understand it and speak truth to it, okay? When we're talking about NSAIDs, non-steroidal anti-inflammatory drugs, okay, those drugs work as first-generation NSAIDs, so naproxen, ibuprofen, aspirin. They work by inhibiting both COX-1 and COX-2. We've talked about that COX-1 is very beneficial to the body. COX-2 is not so beneficial, but unfortunately, the first generations don't distinguish COX-1 from COX-2, and they inhibit both. So yes, they have the potential for bad adverse effects by inhibiting COX-1, such as the bleeding issues, the gastric ulcers, and the renal impairment. We just know that. But they can be very helpful in reducing pain and inflammation by blocking that COX-2. The trouble with them is that it's only aspirin that is protective against MI and stroke. All the rest of them could put you at risk for MI and stroke. Okay, the reason for that is aspirin is very effective at decreasing platelet aggregation, and the other drugs aren't so much. But the other drugs are way more risky to causing worsening problems with vasodilation and other issues that lead to MI and stroke, right? So we know that NSAIDs can be very, very effective for anti-inflammatory and pain, but we worry about them as these side effects that could be happening because of COX-1 and COX-2. We know there's a role in aspirin to be very beneficial and safe to use and can prevent and treat cerebrovascular and cardiovascular disease, right? But the other NSAIDs, such as ibuprofen or like Aleve, naproxen sodium, right? Those ones don't have that beneficial part for the cardiovascular. And they could potentially have the same other kind of troubles, and they could actually cause increase in stroke and heart attack. Okay. So we were very worried about this as a medical community. Oh, these NSAIDs are great, but oh boy. So then they decided, let's see if we can make a selective COX-2 inhibitor only. So everybody was really excited when Celebrex, celecoxib, came out, because the expectation was, in theory, if we only inhibit COX-2, we're going to still have COX-1 present. So we're going to have decreasing risk of bleeding, gastric ulcers, and renal impairment. We're so excited, right? However, what we found is that when you compare NSAIDs to the COX-2s head to head, the COX-2s actually have an even higher risk for MI and stroke. So generally speaking, they've kind of become considered to be less safe than NSAIDs. So it was a really big disappointment, but they still have their place in the market and how to be used. Okay. Table 57.2 is a lovely table to put this all together. You have your first generation NSAID of aspirin versus your first generation of others. Then you have your second generation NSAID, which is your coxibs, and then you have acetaminophen. And it kind of walks you through inflammation, pain, fever, prevention of stroke, whether or not they cause other things. Okay, so if I were highlighting a table under this chapter, I think 57.2 is definitely one I would have tabbed and easy to refer to when you're thinking about how these NSAIDs and these COX inhibitors work. This is a great, beautiful table that lines it all out for you. Okay. So breaking it down a little bit more and talking about these things. Okay. So the prototype drugs that they talk about for first generation NSAIDs, we have aspirin and ibuprofen. For the second generation, we have celecoxib, and for the other one is acetaminophen. So we're going to start with aspirin. This is a wonderful breakdown of really understanding aspirin. We use it so much in acute care medicine. So this is great for you guys to have a chance. Maybe this is review for you, but if it's not, really to make sure this is a concept in your mind that you understand well. Aspirin is cheap, dirt cheap, and has been around forever, but it is a highly valuable medication and still is used for very specific reasons. That is a mainstay of a lot of treatment today. Okay. It can provide excellent relief for pain, for mild to moderate pain from inflammation. It can still be used to reduce fevers, but it's the protection against thrombotic disorders that it really shines, and still remains a drug of choice for rheumatoid arthritis for like pain. So even though we have a lot of newer, quote unquote, sexier drugs on the market, aspirin is still a mainstay drug that you're going to see all the time. Aspirin belongs to the family of salicylates. It's a derivative of salicylic aspirin. Okay, so it is commonly called ASA because of acetylsalicylic acid, ASA. We used to, like on paper charts back in the day, that's how old I am, like the doc would come by and write ASA 81 milligrams daily instead of aspirin. Anyway. Mechanism of action. Aspirin works as a non-selective inhibitor of the cyclooxygenase. So it's non-selective. It's going to affect COX-1 and COX-2. But it's the only drug that has the beneficial protection against MI and ischemic stroke because it inhibits COX-1 at the platelet aggregation part the best. However, it still can have the potential for the bad side effects of gastric ulceration, bleeding problems, and renal impairment. Aspirin is an irreversible inhibitor of cyclooxygenase. Okay. All the other NSAIDs are reversible inhibitors. Because inhibition of the COX by aspirin is irreversible, the duration of action depends on how quickly your specific tissues and sites can synthesize the new molecules of COX-1 and COX-2. So that's why we know that aspirin can have effects in your body for like 3 to 7 days for some people, right? Depending on how they synthesize it and how quickly that goes. Whereas the other NSAIDs, their effects decline as soon as the drug level falls out of your body. So aspirin, right? Like if you've heard that someone's on aspirin, well, they have to wait X amount of days until a procedure. We don't think about that as much with like Aleve or ibuprofen. And that's because aspirin's considered irreversible. Okay. Aspirin is absorbed readily after an oral dosing. It's absorbed in the small intestine, but it also could be given by a rectal suppository because it will be absorbed, but it's going to be more slowly than with the oral dosing. Okay, so if you wanted to get aspirin on board for something, giving it as a suppository is not near as effective as giving it orally or by chewing it, right? It has a very little half-life. Because it rapidly converts to salicylic acid, which is an active metabolite. The rate of inactivation of the salicylic acid depends on the amount present. Okay, so the more you have on board, the longer the half-life may be. It is extensively bound to plasma albumin. So at therapeutic levels, the binding's about 80 to 90%. Aspirin undergoes distribution to all body tissues and fluids, and obviously, because of its protection against the strokes, it crosses into the CNS. It also can cross into breast milk and into fetal tissues. It's widely distributed. Salicylic and its metabolites are excreted by the kidneys. The difference of the plasma drug levels is based on the doses, right? So low therapeutic doses, like an 81 milligrams of aspirin, will produce plasma salicylate levels less than 100 micrograms per milliliter. When you use it at anti-inflammatory doses, that will produce levels of 150 to 300. So if you're giving 325 and you're using that for pain and inflammation, but when you get into signs of overdose and toxicity, then that's definitely over 200, but it's considered severe if you get an aspirin level over 400, FYI. Okay, why do we use the aspirin? Suppression of inflammation, right? So it can still be a great drug for pain control for osteoarthritis, rheumatoid arthritis, and juvenile arthritis. You can also use it for rheumatic fever, tendinitis, and bursitis. The doses can be different. The doses that you need to suppress inflammation are much larger than the dose that you need for pain or reduction of fever. We don't really truly understand actually how and why aspirin works so well to decrease inflammation. We do know that the prostanoids like prostacyclin contribute to several components of that inflammatory process. So when we inhibit it, parts of that is explained that way. But we also know that there's mechanisms of modulation of T cell function, suppression of inflammatory cell infiltration, etc. So it's a drug of choice for inflammation. It works also for analgesia. The degree of analgesia that you're going to get depends on the type of pain. So aspirin is most effective for joint pain, muscle pain, or a headache. If you have a big burn to your leg or a big laceration across the back of your leg or something, aspirin's not the best choice. But if you've got a bad joint, or a bad, back or something with the musculoskeletal joints, especially, it can be very effective. And in fact, aspirin can be more effective than opioids for postoperative pain in some ways as well, which is where we get into like ketorolac, which is like Toradol. But visceral pain, like a bowel obstruction and appendicitis, it's not going to be good for that kind of pain. In contrast to opioids, though, aspirin neither produces tolerance or dependence. So that's good. Aspirin relieves pain primarily through actions of the periphery, and it can help work within the CNS to relieve pain. You can use aspirin as a reduction of fever drug. In febrile adults, it's actually the drug of choice per the data. However, you don't use aspirin to treat children because of the possible Reye syndrome. It will not lower normal body temperature. So it will reduce a fever, but it's not going to reduce your normal body temperature, and it will not lower temperatures that have become elevated in response to physical activity or to a rise in environmental temperatures. That's just fascinating to me. So a fever produced by the prostacyclines and the inflammatory response of infection of some sort, it works on that. But if I go and sit in 130-degree sauna, it's not going to help bring my body temperature down. If I go and run the Boston Marathon, it's not going to bring my body temperature down. It's really, I find that fascinating. Body temperature is regulated by our hypothalamus, which maintains a balance between heat loss and heat production. So a fever occurs when the set point of your hypothalamus becomes elevated, and that causes the hypothalamus to increase heat production and decrease heat loss. That set point is triggered by local synthesis of prostaglandins in response to endogenous pyrogens, which are your fever-promoting substances. And that's where the aspirin can work to reduce the fever in that situation. Okay, one of the biggest things, I keep saying this, of why aspirin is great is because it has suppression of platelet aggregation. So it synthesizes thromboxane 2, TXA2. Aspirin suppresses platelet aggregation by causing irreversible inhibition of COX-1, which is the enzyme that makes the TXA. Because platelets lack the machinery to synthesize new COX-1, the effect of a single dose of aspirin persists for the life of the platelet, which is about 8 days. That is why that part works so differently for surgery. Like if you're on it, people want you to wait 7 days before they do some surgical procedures, because until the platelet actually dies and a new one comes in, that aspirin remains actively promoting decreased platelet aggregation. So there's a section in your book that talks about this that I want to point out to you. Professional labeling now recommends, and the FDA recommends, daily aspirin for men and women with the following. Okay, so if you get, I think it's page 495, it talks about this little section of this paragraph that will tell you when a daily aspirin is recommended. This and this alone is when people should take a daily aspirin. You are going to get asked by your patients, should I just take a daily aspirin just to be safe? And the answer is no, unless you are in this category. Okay, number one, if you've had an ischemic stroke, most people are on an aspirin, so they take a daily aspirin to reduce their risk of death. Number two, if you've had TIAs, same thing. Number three, if you're having an acute MI. Number four, if you've had an MI before. Number five, chronic stable angina. Number six, unstable angina. Number seven, recent angioplasty or other revascularization procedures. Okay? Those are the people that should be on a daily aspirin. The book goes on to specify that when we're talking about a daily aspirin, we're typically talking about the 81 milligram dosing. You don't need to have higher doses because that would increase your risk for GI bleeding. Aspirin can be taken by healthy people for primary prevention of MI and stroke, but we know that aspirin provides less protection against cardiovascular disease than once thought for general population of people. The potential small benefit must be weighed against the major risk of aspirin use, namely GI hemorrhage. To determine the net benefit of primary prevention for any man or woman, you have to look at an individual risk stratification to determine their risk for GI bleeding and compare that risk with their risk for cardiovascular events. Many organizations recommend against the use of aspirin for primary prevention of cardiovascular disease unless the patient has a 10-year risk greater than 10%, right? So you have to do their cardiovascular risk screening. If they have a greater than 10% cardiovascular risk over 10 years, then it may be of consideration that the benefit would outweigh the risk, okay? But by far and away, you don't want every person running around out there to take an aspirin because it can have the potential for GI bleeding and like death. Okay, so when you go to the guidelines and to the literature, from society to society, they still have varying recommendations. So the 2019 American College of Cardiology and the Heart Association recommend a daily low dose of aspirin among individuals 40 to 70 who are at a high risk of cardiovascular disease but not at an increased risk of bleeding. However, they recommend that low-dose aspirin should not be given on a routine basis for primary prevention of cardiovascular disease among adults over 70. Okay. Then you go down to the 2022 U.S. Preventative Services Task Force, the USPSTF. Their statement on the use of aspirin for the primary prevention of cardiovascular disease and colorectal cancer makes recommendations for adults aged 40 or older without known heart disease and without bleeding risk. The decision to initiate low-dose aspirin for people 40 to 59 without known heart disease who have that 10% or greater cardiovascular risk should be individualized, right? But if you're among 60 or older without known heart disease, initiating low-dose aspirin for the primary prevention of cardiovascular disease is not recommended. So it's a hot button topic. To me, as a hospitalist in practice, that is something that I would, if I started it in the hospital, I would turn it over to neurology or cardiology. When I did my cardiology time, we would not be prescribing someone to be on an aspirin unless it was that risk factor was there. And then obviously if you've had the known history and you have the reasons that you should be on it long term, but a lot of education into the risk of it needs to happen. People think that an 81 milligram of aspirin is a pretty benign dose, but it's not. That is enough to cause some major, potentially fatal side effects from GI bleeding. So it's not something to just be taken lightly. There is evidence about colorectal cancer and aspirin to be given for colorectal cancer prevention. In 2010, there was a study that said if you take it for more than 5 years at the low dose, the incidence of colorectal cancer decreased by like 35%. When we go into the more current literature, when you go to the literature, it is interesting because there was a lot of data suggesting, that this could be great. It's interesting to note that the controlled trials that have been carried out thus far in patients were done in patients with a history of colorectal neoplasia. They either had an adenoma or cancer, but they weren't done in patients at average risk for adenoma development. So that kind of confused the issue, and it's been looked at a lot. So most of the data is going to suggest that it could be very protective if you have people that have the history of adenomas and they can take it for 5 years, etc. So as of 2024, though, the United States Preventative Services Task Force no longer recommends low-dose aspirin for primary prevention of colorectal cancer in the general population because there was a lot of variables and a lot of concerns, and it just didn't pan out into the safety. And the reason that also is because you really have to be on it for a long time. It was at least 5 years to get that benefit from it. So now there's still a lot of research being done if you have family history, if you've already had an adenoma, etc. So that's one area you may encounter people that take it for colorectal cancer prevention, and that's great. You may see that. going on and talking then about the adverse effects of aspirin. When you use small doses short term for like fever reduction, people don't have a lot of trouble. You get into trouble with aspirin when you're taking it every day for like chronic inflammatory conditions like your rheumatoid arthritis, or for chronic every day for things like your heart. Okay. The most common side effects are GI, gastric distress, heartburn, nausea. They suggest that you take your aspirin with food and a full glass of water. You also are at risk for occult GI bleeding. And occult means kind of silent over time. In most cases, the amount of blood loss each day is insignificant, so that you don't have bright red or melanotic stools. But over time, like 3 years, it becomes enough that you can produce anemia. Long-term aspirin, even in low doses, can cause life-threatening gastric ulceration, perforation, and bleeding. Okay, there's 4 causes of that. You have increased secretion of acid and pepsin, you decrease that cytoprotective mucus and bicarbonate, you decrease your blood flow, and then you have a direct irritant of the aspirin itself. The direct injury to the stomach is most likely with aspirin preparations that dissolve slowly because they sit in your stomach longer. Because aspirin-induced ulcers are often asymptomatic or occult, they can occur, you can have all of a sudden deadly GI bleeding without any premonitory signs. Okay, I want you guys to also highlight and know these things. The factors that increase the risk for ulceration are what? So when we say, well, you should weigh the risks and the benefit, the risk of bleeding versus whatever, who's at highest risk of bleeding, okay? They are people with advanced age, especially 80s and 90s, history of already having gastritis, peptic ulcer disease, erosive esophagitis, those things. If they have a history of intolerance to aspirin or other NSAIDs, and cigarette smokers. Okay, that's a whole lecture for a whole different day, but you really have to understand the importance of cigarette smoking as a huge, huge risk factor for gastrointestinal bleeding. And then routine alcohol use. Okay, so to prevent ulcers, what do we do? I love this little section here because it is such a diplomatic politician type response. Okay, so what can we do to prevent ulcers? According to the expert panels by like American College of Gastroenterology, American College of Cardiology, etc., prophylaxis with a proton pump inhibitor is recommended for patients at risk. Okay. They include risk to also include people on steroids, which I agree. Please put that on the list. PPIs reduce ulcer generation because they suppress the production of gastric acid. Other drugs also, like H2 receptor antagonists and misoprostol, could also do that. Because many ulcers are caused by infection with H. pylori, the panel recommends that patients with ulcer history undergo testing and treatment if they do have H. pylori before they start long-term aspirin. Okay? Okay, sounds good. So now we're saying, well, maybe if we put you on a PPI, it could be safe to take those aspirins, right? Etc. Okay, moving on. Aspirin, bad side effect possible, bleeding. Aspirin promotes bleeding by inhibiting platelet aggregation. Taking just 2 325 milligram tablets can double bleeding time for a week. Because of its effect on platelets, aspirin is contraindicated in patients with bleeding disorders such as hemophilia. To minimize blood loss during childbirth and elective surgeries, high-dose aspirin should be discontinued at least 1 week before these procedures. Okay? There is no need to stop your aspirin before low-risk bleeding like dental surgeries, cataract surgeries, those things. In most cases, use of low-dose aspirin to protect against thrombosis should not be interrupted for elective surgery and dental procedures. So, 8 months ago, you had a major heart attack and you're still on an aspirin, and now you need to go have your knee replaced. Okay? Now what we're saying is that we're not sure, and we don't recommend anymore stopping that aspirin because it's so important to be preventative and protective and there's not always a great risk of bleeding and a knee replacement, they say go ahead and keep taking the aspirin. In patients taking daily aspirin, if you have high blood pressure that's poorly controlled, it's going to put you in an increased risk for a hemorrhagic stroke. Even though aspirin protects against an ischemic stroke, if you take aspirin and you have uncontrolled high blood pressure, you're at risk for a bleeding stroke. Okay, so the goal is to have at least lower than 150 over 90 before you would start your daily aspirin. Next adverse effect. We said we've talked about the GI, we talked about the bleeding, now we got to talk about the renal impairment. Aspirin can cause acute but reversible impairment of renal function, resulting in salt and water retention and edema. Okay, you're typically going to see this at people who have additional risk factors like advanced age, already bad kidneys, they get super volume contracted, they have cirrhosis or heart failure. Okay, those are the people that tend to have the biggest problem with aspirin in their renal function. Aspirins deprive the kidney of prostaglandins that's needed for normal function. You should start to see problems when you could see reduced urine output, weight gain despite being on diuretics, or rapid rise in serum creatinine and BUN. If any of those occur, the aspirin should be withdrawn immediately, and you would wait for the function to return to baseline and then decide if it's something you could be put back on or not. All right, the next one is salicylic acid is at risk for salicylism, which is a syndrome that can develop when aspirin levels climb just slightly even above therapeutic levels. The overt signs that you could see are tinnitus, which is ringing in the ears, sweating, headache, and dizziness. So if you're on a daily aspirin and you develop ringing of your ears, that's something you need to report to your doctor. You can also develop acid-base disturbances. If you get salicylism, you withhold the aspirin until the symptoms stop, and then you resume, but usually at a lower dose. In some cases, people use the development of the ringing of the ears as the sign that, okay, we've reached our maximal dose, now we need to cut back a little bit. But that guideline is really not in practice anymore, but you may still hear of it being done. Acid-base disturbances can result from the effects of aspirin on your respiration. When you get it in high enough doses, aspirin can act on the CNS to stimulate breathing, so you get a resultant increase in CO2 loss, and you become alkalotic, and in response, the kidneys excrete more bicarb, and so now you have a buildup of acids resulting in a metabolic acidosis. So patients who have salicylic toxicity are really at risk for this acid-base disturbance. In children younger than 18, you can have the possibility of Reye syndrome. It's much more common in younger childhood, but it has a mortality of up to 20 to 30%. Characteristics are encephalopathy, fatty liver degeneration. It seems to be highest when you're using aspirin by children who have influenza or chickenpox. We just don't use aspirin in kids. That's something that you're just going to see only in very specific circumstances. Most of the societies will tell you you avoid it even in teenagers, especially if they're suspected of having influenza or chickenpox. Especially because you can just use Tylenol. During pregnancy, aspirin can be a big problem. So listen up and star this in your book. This is a type of question you will get on a board certification someday. Aspirin poses risk to the pregnant patient and the baby. The principal risks to pregnant women are anemia from GI blood loss, but also postpartum hemorrhage. In addition, by inhibiting the prostaglandin synthesis with aspirin then can suppress spontaneous uterine contractions and can prolong labor. Here's the thing, aspirin crosses the placenta and may adversely affect the fetus. Because prostaglandins help keep the ductus arteriosus patent, inhibition of prostaglandin synthesis by aspirin may induce premature closure of the ductus arteriosus of the fetus. Aspirin use has also been associated with low birth weight, stillbirth, renal toxicity, and hemorrhage in preterm infants, and has even led to neonatal death. So aspirin use in women in pregnancy, that is something a specialist would decide to do or not to do. But generally speaking, you're going to be advised not to take aspirin during pregnancy. So the summary of that is that it should be used with extreme caution in pregnancy and children who have chickenpox or the flu. You also have to be worried about it when they're at high risk for bleeding. Aspirin's most important drug-to-drug interactions as a possibility to worry about with this drug is other anticoagulants. So because aspirin's suppressing that platelet function and can decrease prothrombin production, it can intensify the effects of warfarin and other anticoagulants. Also, because aspirin can initiate gastric bleeding, augmenting anticoagulation effects can increase then your risk for bleeding. So the combination of aspirin with other anticoagulants has to be used with care and is usually done through specialists type of situation. Aspirin and steroids. Like aspirin, steroids can promote that gastric ulcer issue, so that's why you have to be very cautious with use of aspirin and steroids. If they do need to be on both, they're often on a PPI or an H2 blocker. You have to be very careful with aspirin and alcohol, right? Because you are at risk for increased bleeding. Here's the other issue. If someone is taking a baby aspirin, like for cardiovascular disease, right, because we know it's preventative and protective, but then they try to take another NSAID like ibuprofen, the other NSAID will reduce the antiplatelet effects that you do get of aspirin, because now you're blocking access of aspirin to COX-1 and platelets. So it's really important to understand that, because in patients taking low-dose aspirin to prevent MI or stroke, other NSAIDs could negate that benefit. So even if they're, for like I strained my back, so for 5 days I was also taking ibuprofen, there's a high likelihood that during that time they're taking both, they are decreasing the protective nature of the aspirin and putting themselves at risk. The other one that they worry about as well is aspirin and ACE inhibitors, or ARBs, and that's because of the potential for issues with renal function. But how many people do you know with heart issues that are on both an ACE inhibitor and an aspirin? It happens all the time. It's just important to understand that you have to be monitoring the renal function. The other thing they talk about in your book is that aspirin and all the NSAIDs may blunt the immune response to vaccine. So you don't necessarily want to give these drugs to prevent vaccine-associated fever or pain. It's best to not take anything. All right. Other drugs. When you go to table 57.4, they go through and describe all of the NSAIDs and what they are. There's 1,000 names out there for these. Like you have phenoprofen and ibuprofen and ketoprofen and naproxen and diclofenac and etodolac and indomethacin and ketorolac and meloxicam and piroxicam and Cilindac and all these ones. And then you have the second generation celecoxib. I do want to point out that meloxicam is still considered the first generation NSAID and blocks both. The truly only COX-2 inhibitor that we have is Celebrex, celecoxib. Remember, though, that in contrast to aspirin, the non-aspirin NSAIDs do not protect against MI or stroke, and they actually will increase the risk for thrombotic event. Of the NSAIDs, indomethacin, Cilindac, and meloxicam are at the highest for the risk of cardiovascular events. You don't want to use NSAIDs before coronary artery bypass grafting or for 14 days after as well. All right, let's then move on to ibuprofen. Oh my gosh, everybody takes ibuprofen, I swear. So this is Advil and Motrin. Like aspirin, ibuprofen inhibits the COX and has anti-inflammatory, analgesic, and antipyretic action. The drug is used to treat fever, mild to moderate pain, and arthritis. Also, ibuprofen appears to be superior to other NSAIDs for relief of primary dysmenorrhea, right? So because they think it's something to do with the uterine smooth muscle contractions. So if you have very painful or heavy bleeding or painful cramps with bleeding, ibuprofen is by far and away superior to acetaminophen or aspirin. It's pretty well tolerated and it works really well. And again, it has probably less gastric bleeding than aspirin, but is still a worry. Ibuprofen is among the safer NSAIDs for use with anticoagulants, so that's good to know. There has been rare instances of ibuprofen being associated with Stevens-Johnson syndrome. And again, ibuprofen still has that risk for increasing your risk for MI and stroke. The other medications that they talk about, like magnesium salicylate, sodium salicylate, and salsylate, are non-acetylated salicylates, are similar to aspirin, but they are a bit different. And those drugs, again, should not be given to people with the flu or chickenpox. The other non-acetylated salicylates do not give you the protection against stroke and MI. It is only aspirin. Okay. The black box warning that comes with first generation NSAIDs, all of them, aspirin, ibuprofen, everything, has a black box warning for being associated with increased risk of GI bleeding and cardiovascular events that can lead to hospitalization or death. So all of them have a black box warning and they are all available over the counter. That's interesting to me because does the general public know that? Does anybody read that on the insert? Probably not. All right, specifically, let's go on to Celebrex next. Sorry, celecoxib. It was the first one made, so it is our prototype. It is a great drug for rheumatoid arthritis, ankylosing spondylitis, acute pain, and could also be used for dysmenorrhea. It's also off-label for a rare genetic disorder known as familial adenomatous polyposis, the FAP, because that predisposes people to colorectal cancer. But for patients with arthritis, celecoxib is equal to naproxen at relieving joint pain, stiffness, and swelling. But owing to the concerns about cardiovascular safety, celecoxib is considered a last choice drug for long-term management of pain. But the nice thing about it is it's dosed every 12 hours, and some people just don't respond to ibuprofen as well as they do to celecoxib. You will have people that it doesn't do the same thing. Remember that celecoxib does not provide cardiovascular benefit of aspirin. Okay, it is only inhibiting COX-2, which is great. So it's supposed to be safer and cause less bleeding, less GI issues, and less renal impairment. It is well absorbed after oral administration, and it's extensively bound to plasma protein. Because of the COX-2 specific part of it, we really were excited that it's not going to cause as much issues of bleeding. When you look at long-term use of 12 months of using an NSAID versus celecoxib, there was no difference in the risk of GI bleeding, which is good. Celecoxib may be even safer in the short term than NSAIDs, but there's not good data to support that yet. And oftentimes you're going to give celecoxib maybe with a PPI to help prevent GI upsets. The problem with the celecoxib is that, like other non-aspirin NSAIDs, celecoxib can increase the risk for MI and stroke, which stinks. So really the recommendation is going to be that you should use it for the lowest dose for the shortest time that you need. The drug should be avoided in patients with existing heart disease, avoided with people with CABG, very cautiously used in people with big risk factors such as hypertension, diabetes, or dyslipidemia, especially poorly controlled of those, and also people at risk with the diabetes or who have poorly controlled diabetes. The reason that they think it even has a higher risk for stroke than the NSAIDs is because it only is inhibiting COX-2. So COX-1 platelet aggregation is not suppressed. So those two factors together causes unimpeded platelet aggregation but increased vasoconstriction, and that is what increases the likelihood of thrombosis. It can still involve renal impairment, but it seems to be less. You have to be careful with sulfonamide allergies if you want someone to be taking Celebrex, and so we tend to avoid Celebrex if they have a sulfonamide allergy. You cannot use Celebrex in the third trimester of pregnancy. You have to be careful with warfarin and other DOACs. The other big one is that celecoxib is very carefully dosed if people are on antifungal drugs or lithium. There is a summary of your key prescribing considerations for your NSAIDs in your book, but I think do a great job of kind of lining this out as well. You know that you have to be careful in extreme caution in patients with peptic ulcer disease, bleeding disorders, and anticoagulants, etc. So that's kind of a nice summary there. All right, we're moving on. I hope you're hanging in there with me. Next one is acetaminophen. People use acetaminophen like candy. It's very safe. It's really well tolerated. It works really well, but you have to know what you're doing. And definitely how to educate your patients well. Acetaminophen is the only not anti-inflammatory COX inhibitor. It has both analgesic and antipyretic properties that are equivalent to aspirin, but again, it is devoid of any use for anti-inflammatory action. It does not suppress platelet aggregation, and it does not cause gastric ulcer, and it does not decrease renal blood flow, does not impair your kidneys. However, it now has a significant issue if you use it incorrectly with liver damage. In the United States, it's the most used analgesic over the counter. How does it work? The differences between the effects of acetaminophen and aspirin are thought to result from selective inhibition of cyclooxygenase, right? Aspirin can inhibit COX in both the CNS and the periphery, but inhibition by acetaminophen is limited to the CNS. So acetaminophen has only minimal effects on cyclooxygenase at the periphery sites. But by decreasing prostaglandin synthesis in the CNS, acetaminophen is able to reduce fever and pain. So the inability to inhibit prostaglandin synthesis outside of the CNS is likely to explain why it also, though, doesn't have anti-inflammatory properties, but it doesn't cause gastric ulceration, and it doesn't affect your kidneys and your platelets. It is readily absorbed after oral dosing, and it has wide distribution. We know it's metabolized by the liver, and the metabolites are then excreted in the urine. Plasma half-life of acetaminophen is only about 2 hours. It can be metabolized by 2 pathways. When you talk about optimal dosing then for acetaminophen for years, you know, we've always been told to never go above 4,000 milligrams or 4 grams in a 24-hour period. That's still thought to be generally tolerated for generally healthy people, but hepatotoxicity has been reported even in people between 3,000 and 4,000, although it's more rare. So now most experts are saying that you really should aim for 3 grams or less a day in adults, even with normal liver function, if they're going to be on it longer term. But now there's also recommendations that it's actually less than 2 grams a day. If you have certain risk factors for hepatotoxicity, such as drinker of alcohol, malnutrition, fasting states, low body weight, or advanced ages, A lot of times now in the hospital setting over the age of 75 or 80, you likely will get notified by your pharmacist to decrease to less than 2 grams a day. Or if they already have evidence of liver disease, you're probably going to be encouraged to reduce that. If somebody already has liver impairment, you would go to their, their Pew class and determine whether or not they would be safe to take it. Typically, they can use it if it's less than 1,000 milligrams a day. Some people will say 2,000 milligrams a day, but that's kind of how that is dosed. And of course, in children, we typically do weight-based dosing. Even if you treat children down to 13, you may have to give that into consideration if they're a very small 13-year-old. Most times by 13 to 18, they are of adult body weight and can handle the normal dosing for adults as well. If you're on warfarin and you're taking acetaminophen and they're going to be taking it routinely greater than 1 gram a day, they don't understand why, but it does seem to affect their INR, which is surprising because acetaminophen doesn't actually suppress platelet aggregation, so it doesn't promote bleeding, but it does tend to higher doses for a longer period of times can alter people's warfarin, so they have to be monitored closely. And again, it carries the same thing with vaccines that you should really try to avoid acetaminophen or ibuprofen or NSAIDs immediately after vaccines, even in childhood, because it can blunt your vaccine response. All right, briefly, we're going to touch a little bit on acute toxicity or overdose of acetaminophen. In the United States, intentional or unintentional overdose of acetaminophen is the leading cause of acute liver failure of over 50 cases. And again, if you have people that are fasting or they have chronic alcohol use or they sometimes take more than the 4,000 milligrams a day, they're also at increased risk. The biggest clinical or principal feature, I would say, of acetaminophen overdose is hepatic necrosis. So severe poisoning can progress to fulminant liver failure, coma, and death. People that do overdose on it, like intentionally, early symptoms of the poisoning would be nausea, vomiting, diarrhea, sweating, or abdominal discomfort. And even if they have very mild symptoms initially on presentation, that does not belie the severity of the overdose. It's a very serious thing and they require close monitoring. So they could present to your emergency room very asymptomatic appearing, but you calculate the dose that they took and they're going to get hospitalized because it's not until 48 to 72 hours after your ingestion that you could see the degree of hepatic injury that could occur. So we know that the treatment for acute overdose or toxicity of acetaminophen becomes acetylcysteine, which is called Mucomyst. It's also referred to sometimes as acetadote. It is the specific antidote to acetaminophen toxicity. It works by reducing injury because it's a substitute for the depleted glutathione in the reaction that converts to that toxic metabolite. So when you give somebody who's had a Tylenol overdose acetylcysteine, you are substituting this process here so that the liver can convert these toxic metabolites into non-toxic metabolites and you don't have the sustained liver injury or failure. The trick of it is that in order for this to be effective and to work, it has to be given at the correct time. So when given within 8 to 10 hours of your ingestion, it's 100% effective at preventing severe liver injury. However, when administered even as much as 24 hours, it has still been very, very helpful. But after 24 hours after ingestion, if they haven't really had any symptoms yet, depending on their dosing, they still would be having to be hospitalized until at least 48 to 72 hours to ensure that there's no underlying liver injury. And again, that's even if they appear fairly asymptomatic, which is really confusing for people because if they don't look that sick, sometimes people can kind of disregard them saying of how much they took, but you cannot do that. Because they can still have significant liver injury. They talk about there in your book about minimizing the risk. You can read through that. We've already spoke of all of those. There. All right, so that kind of wraps up our NSAIDs and COX inhibitors. As always, please reach out if any questions or concerns. Thanks.